Hello and welcome to TB Ed Talks, a series from TB Fighters where we sit down with experts in the world of TB and learn about the thing that they are the expert in. My name is Tori. I will be your host tonight, and with me is our very special guest, Dr. Melino. Dr. Melino is a physician and global health leader whose work centers on the transformation and strengthening of health systems in resource-limited areas. He has held a lot of senior leadership positions across his career, including he's currently the Senior Health and Policy Advisor at Partners in Health, and previously he was the Executive Director of PIH Lesotho, and he has an incredible presentation prepared for us tonight. So, Dr. Melino, I will hand it over to you.
Thank you so much, Tori. Hello, everyone. I'm Melino Ndayizigiye. I'm currently serving as the Senior Health and Policy Advisor for Infectious Diseases for PIH. I'm going to talk about a very good topic, a very concerning topic on understanding TB challenges to global eradication. This is the content of what I'm going to take you through. I have few questions, just basic questions on knowledge of TB, and I'm going to share my personal story about TB, and also talk about different forms of TB and why the world is failing to end TB, and the complexity of TB diagnosis and the long-term impact of TB on survivors. And I'm going also to share information on PH strategy to achieve TB elimination. And lastly, I'll be talking about the gaps in terms of TB funding. Just a few questions. Very, very basic. Feel free to respond. I will give you the answer at the end of each question. Who is at risk of getting TB? The first one, immunocompromised patients, elderly, children, people living in low income countries. Everyone is at risk. So which one is the good answer?
I'm going to stand in for the audience for a second, but I'm going to say that everyone is at risk. We say a lot that if you breathe air, you are at risk for TB.
Exactly. Everyone is at risk. The second question is, can someone who has been treated for TB and cured become infected again? The first answer is no. TB treatment gives immunity to people who have successfully completed TB treatment. Second answer is yes. Someone who has successfully been treated for TB and get cured can still get infected and die from TB. Which one is the best answer?
I know this one too. The answer is yes. And I wish it wasn't.
Yes. You can definitely still get infected and get, and die from TB if not treated. The last question is, TB is an airborne disease that affects the lungs and does not spread to other parts of the body. Yes? No?
And so, unfortunately, I wish I was going to be wrong about this one again, but it's no. You can get TB. We hear about it we can talk about raw milk later.
Yes. No, TB can spread to other parts of the body, and I will come back to that. Let me now share my personal story. So in 2007, I started my career as a medical doctor after graduating from the National University of Burundi. I decided to go to serve in rural communities where I was serving I moved to a rural district to work in a district hospital. Uh, I was the only uh, I was only one doctor in that district, and I was seeing patients, many patients with a wide range of diseases, including TB. Our TB diagnostic capacity and infection prevention control was very limited. Um, we had no X-ray machines. We had no molecular testing capacity. We only relied on one microscope. We're taking sputum sample and just analyzing the sputum sample in a microscope. Um, it was not easy. In 2008, I was recruited by another NGO, Village Health Fox. I worked there for 4 years, and I was seeing many patients, around 80 patients per day, including rounds in the clinic. Um, there also, our diagnostic capacity was very, very limited. We had no gene expert machine. We had an X-ray machine, but we had no the new technology like AI. So our prevention control was limited. We had no IPC tools like N95 masks, but we were still seeing patients. In 2012, I was accepted into a master's degree program at Harvard Medical School. And one of the requirements for international students was to get tested for TB. And I was asked to do a skin test called PPD, which became positive. At first, I thought, oh, maybe this is because I have been vaccinated. I got BCG vaccine. And for people who have got BCG vaccine, the skin test can still be positive, can be positive. The the chest X-ray was normal. So I thought maybe, this is because I got BCG vaccine when I was a kid. When I arrived in the US, I took more advanced tests. I got tested with quantiferon TB Gold test, which came positive, and that confirmed that I had been infected with TB. So fortunately, it was a latent form, and I took TB preventive therapy for 3 months. Um, are you still see my screen?
It disappeared for me, so maybe not.
Oh, okay. Yeah,
It's back.
yes. So I took a quantiferon gold, which became positive, and that confirmed that I've been infected with TB. So I took TB preventive therapy for 3 months, and I completed TB preventive therapy. I kept thinking, if I didn't have a chance to come to US and get this advanced test, um, probably I will not be alive now. The latent TB infection that I had could become active and kill me. I could have infected my family members, my colleagues, and anyone close to me. And this gave me an inspiration to really start the fight against TB. Um, let me. I'm trying to move my slide. Let me try to share again.
It's the perpetual struggle of the slides in the meeting.
Yeah,
Happens every time.
yeah, I see this. Uh, let me share again. It is. Yeah. Excuse me.
While you're working on that, I can tell you the chat got all of the questions right that you asked. We got a good
Amazing.
grade on our TB test.
Amazing. Amazing. Um, um, okay. All right. Now I'm going to move into to go deep into understanding TB. As we said, it is an airborne infectious disease, and everyone can get it. And right now, the World Health Organization is estimating that 1 in 4 people in the world has been infected with TB. And despite being a preventable disease, an estimate of 10 million, 10.7 million people fell ill worldwide in 2024. And that is about 3,370 a day. And one every 30 seconds, there is one person infected.
Can
And
I
also,
ask, sorry, one clarifying question there?
yeah,
Sorry to interrupt. Um, but when we say 25% of the world's population is infected, that includes people with latent TB, right? And then the
exactly.
10.7 are the people with active disease. Is that the difference there?
Yes, yes,
Okay.
a combination of both.
Yes. Thanks.
And despite being a curable disease, each year there is 1.3 million people who die from this disease. And over 80% of them live in low and middle income countries. And now let's try to dig deep and uh, understand the forms of TB. There are two main forms. There is an active TB disease. This is the form of TB in which the bacteria is actively replicating and causing symptoms. It can spread to other people, it can infect other people. If not treated, it can damage other organs and can become life threatening. There is another form that we call latent TB. In this form, the bacteria remain in the body in an active state. People with latent TB do not feel sick and cannot spread the disease. However, if the immune system becomes weakened, the infection can become active. Um, there are also other two main types of TB. There is drug susceptible TB that we call DSTB. This is a type of TB that responds to first line anti-TB drugs. There is another type of TB that we call drug-resistant TB. This is a type of TB where the bacteria is resistant to isoniazid and rifampicin and requiring more complex treatment. And we also have different types of TB based on the locations. There is something we call pulmonary TB. This is a form of TB that affects the lungs. It is the most common type of TB and most contagious. There's also extrapulmonary TB, and we see this in many countries. Even here, there are different forms of like extrapulmonary TB. This is a form that affects organs outside the lungs, such as the brain. You will hear something called TB meningitis, the heart, TB pericarditis, where TB will affect the heart, and someone will develop pericardial effusion, and it can also affect the eyes. You will hear something called TB uveitis. It can affect the bones and many other parts of the body. So coming back to the previous question, yes, it can spread to any part of the body.
The eyes is a new one. I hadn't heard that one before. That sounds really gross, and terrible.
Yeah, yeah, it is. It is terrible. Yeah, TB it is
Yeah.
terrible.
Oof.
Yeah. And why is the world failing to end TB? There are different reasons. One, limited access to screening and diagnostic services. Many high burden populations, such as people living in poor communities, migrants, prisoners, they lack adequate access to screening and testing services, and this leads to delayed diagnosis and continued transmission. Um, sorry, it is stuck again. um, Let me stop sharing and reshare. Um,
I had another question for you while
yeah,
you were bringing that up, and it completely forgot it. So,
yeah.
yeah.
Okay. Um, the second reason why the world is failing to end TB, there is a high cost and limited availability of diagnostic tools. Modern diagnostic tools like X-ray, digital X-ray machines, molecular testing tools like gene express machines, TrueNAT machines, they're quite expensive. Um, when you look at uh, the capacity of the rural and poor communities. And these costs limit the widespread implementation, especially in low and middle income countries. For example, an X-ray machine can go up to 100,000 US dollars. Um, Inadequate effectiveness of TB vaccine. Uh, I'm sure you know about the BCG vaccine. This is the old vaccine available. It is not really effective. It can prevent, for kids to develop severe form of TB, but it doesn't prevent someone to get TB. The absence of a highly effective vaccine across all age groups remain a major scientific and public health gap. Weak and economic support uh, for TB patients. TB patients is linked to poverty and social determinants of health. Many patients face financial hardship, stigma, and lack of social protection. And these are key barriers to treatment adherence and health-seeking behavior. There are also gaps in early detection and prevention system. A large proportion of TB cases remain undetected or undiagnosed or diagnosed late, partly due to reliance on passive case finding rather than proactive screening. When we talk about passive case finding, it's when we wait in the clinics for patients who are sick to come for screening. And active case finding is when we go out to screen the community and try to find TB cases. Six is on health system and funding limitations. I will come back to this in my last slide. Sustained investment and strong health system are required for TB elimination, but many countries struggle with resource constraints, workforce shortage, and competing health priorities. Now I'm going to talk about how complex is TB diagnosis. I picked two articles. They are available online. One was published in 2024 on prevalence of subclinical TB in adults in the community. This article, it is a meta-analysis. It has analyzed TB prevalence surveys from 12 countries, looking at the burden of subclinical TB in the community. And one of the striking findings was up to 59% of patients had no persistent cough. So it is hard when someone doesn't have symptoms to really diagnose. Another article, this one, was published in 2020 in the Oxford Press for Infectious Diseases. It has analyzed over 20 TB prevalence surveys from Africa, from Asia. And one of the striking findings was 50.4% of TB patients had no symptoms, which means there are a lot of people who don't have symptoms, but who have active TB. And TB doesn't just kill, it causes long-term damage. There's something that we call post-TB lung disease. And this is one of our patients in Lesotho, Keza Mahapa, who has completed TB treatment. He had MDR TB, but TB has destroyed his lungs, as you can see here. Now he's dependent on oxygen. He cannot live without medical oxygen. We have to supply medical oxygen all the time. And globally, the global burden of post-TB lung disease is estimated about 91.6 million of people. They live with post-TB lung disease worldwide. And this is according to a study that was conducted. It was published in 2024. And the post-TB lung disease accounts for 47% of the total TB disease burden in terms of disability adjusted life years. And this is a combination of years lost because of TB and years lived with disability because of TB. So, and in 2020, there was another article that was published in 2020 that showed that there were 155 million TB survivors, and 59.1 of them had abnormal lung function test because of TB. So, which means they are living a poor life even after completing the TB treatment. Now, I'm going to talk about the TB PAH TB strategy to achieve TB elimination. PAH is undertaking a very ambitious project in Lesotho, where we are trying to really demonstrate that it is possible to eliminate TB. And for those who don't know Lesotho, this is this is a country landlocked inside South Africa. It has one of the highest TB incidence in the world. It is the current incidence is 548 per 100,000. And the treatment coverage is only 51%. The TB case, which means 49%, almost half of TB patients are missed to treatment. And the treatment success rate for those who have been initiated on treatment is only 82%. And the case fatality ratio is 36%, meaning 36% of TB patients, they die. And this leads to a very low life expectancy. Currently, Lesotho has one of the lowest life expectancy. It is 53. Here in the US, I think it is close to 80. And how PAH is doing to really achieve this TB elimination? We have three pillars of our strategy. The first one is on search. How do we search for TB? Previously, I talked about passive case finding. What we are doing is active case finding. We are conducting community outreaches and intensified screening for TB. We have developed a system that we call TB Hunter. I led the development of this system. It shows real-time data on each of the TB care cascade. And we are also using decentralized diagnostic tools, point of care, molecular test that helps to test TB and get results on the same day. We are also using GIS to identify villages with high number of TB patients that we suspect that these might be hotspots. And how do we approach treatment? This is the second pillar of our strategy. Patients with drugs sensitive TB are managed at the health center and they get social support. And those with drug-resistant TB, we refer them to a district hospital where they get care. But those who are critically ill, we refer them to our MDR-TB hospital, where we have a dedicated intensive care unit for those who are critically ill. We have also integrated screening and management of possible lung disease. And this is one of the cascade that was actually missing when you look at the global recommendations on TB care cascade approach. And how do we approach the prevention? This is the third pillar on prevention. We are conducting community contact tracing, and we have nurses who are dedicated to do this TB contact tracing. And the way we are doing contact tracing, we don't only go and ask for symptoms, because we know majority of them will not have symptoms. If someone has been in contact with TB today, that person will not develop symptoms the next day. So we need to use advanced, screening tools like portable X-ray machines, artificial intelligence, teleradiology, to really make sure that we do proper screening. We also provide TB preventive therapy at the community and at the facility level. We also use the TB Hunter system to make sure that all contacts have been screened and they receive TB preventive therapy. We use what we call 5 S's. This include well-trained staff and staff in terms of equipment, like these digital X-ray machines, point-of-care ultrasound machines, point-of-care molecular tests like TrueNut, GeneXpert machines. We have space where we use like mobile vans equipped with digital X-ray machines. We have also systems that I just talked about, the TB Hunter system, the teleradiology, the artificial intelligence, and we provide social support to the patients, because we know these patients are very poor and they struggle to even have a meal for the day. And this is the system that I was talking about, the TB Hunter system. This is a system that we developed. It is an innovative platform that integrates real-time AI-supported screening, testing, treatment initiation, contact tracing, and patient follow-up, including screening and management of possible lung disease. This is just a screenshot of how the data looks like today. We have screened over 60,000, like close to 60,000 people, and you can see like out of those people screened, we have around 23% of them are presumptive, meaning they are likely to have TB. And we have tested 81.1% of them, and we have diagnosed 3.4% are have been diagnosed with TB, and all of them have been initiated on TB treatment. And on the other column here, this is a cascade on contacts where we have close to 2,000 household contacts, and we tested 1,257, and we have initiated over 500 on TB preventive therapy. And this is how we do community-based active case finding using GIS. And this GIS is embedded into the TB Hunter system, where we can see, like in this village, Halpekola, it is this village located here. These are like the geolocation of TB patients. And as you can see, this village here, when I have 7 patients with active TB, the likelihood for this village to, to have been infected, I mean, everyone in this village to have been infected is very high. So we consider this village as a potential TB hotspot, and we go there with portable X-ray machines and point-of-care molecular testing tools, and we screen everybody. We test everybody. Those who are screened negative are initiated on TB preventive therapy, while those who are confirmed to have TB, active TB, are initiated on TB treatment. This is my last slide. It is about the funding gap. TB elimination requires a lot of resources. There is a significant funding gap in the fight against TB. According to the World Health Organization, in 2024, only 5.9 billion was available out of an estimate of 22 billion needed for TB services. This was just about 27% of, of the budget needed. If this trend continues, we are likely going to see a rise of TB cases, an increased mortality, and the spread of more drug-resistant strain. And the world will be in a terrible situation. We must sustain and strengthen our efforts, advocating for increased investment and resources to combat TB and protect the global health from this deadly disease. I will stop with this quote from our beloved Dr. Paul Farmer, who said, "The idea that some lives matter less is the root cause of what's wrong in this world." Thank you very much for your attention. I'll be happy to respond to any questions.
Yes, and we have some questions coming in, but first of all, thank you for all of that. It's always great to hear from people who have like firsthand experience in this world of TB. A lot of us in TB fighters, we have only just started meeting TB survivors. None of us have a lot of personal experience. So every time that we get to share in somebody's actual lived experience with us, it brings so much to us. Just we get better at being advocates, and we remember that there the humanity in this project. So we're very grateful for that. So my first question is, other than funding, because obviously funding is the big one, right? Could you talk a little bit about the other barriers to providing TB care in Lesotho? Like I know that it's the money is the first part, but it's not that simple.
Yeah, good question. Yeah, the main issue in countries like Lesotho is access to services. People live far away from the clinics, and when someone has TB, that person it's very weak. You cannot travel long distance on walking. It's not possible. Um, and people will stay home. And the sad thing about Lesotho and many countries, I by the way worked in other countries as well. The main problem is the primary health care facilities, the health centers. They don't have diagnostic capacity. You will find that they don't have even a lab. They don't have a lab, and those are the first facilities where someone with TB will consult first. And when they go there and they don't even have a gene express machine, they don't have an X-ray machine, then they are asked to go to a district hospital for a chest X-ray, which is, you know, 20 miles away. They don't even have money for transport. They will end up not going there. So the access to screening and testing tools is very limited. And when I'm talking about the funding gap, if the world has can allocate enough funding to strengthen the diagnostic capacity, can be one of the great things that can be done towards eradicating TB.
It's the stuff, right? In the five S's, the stuff
Yeah.
is where that funding really goes. So one of our questions from Connor was, how did your own experience with TB kind of impact your interactions with your patients?
A good question. First of all, when my experience with TB, when you receive a result that you have been infected with TB, you have a lot of questions, and you feel like, oh, okay, am I having? Did I have I been infecting people? Who did I infect? And who else needs to be tested? And you become anxious. Although TB medications are free, but you think about how long have you been infected, and how many people have you infected, and how can you let them know that you have been infected and they need to go for screening? Those are like a lot of questions that any TB patient will fear, and people with families will feel like, okay, I have infected my family, I have infected my colleagues, I have infected so it is quite a challenge, and how I approach it, I always you know uh, reassure them that yes, TB is an infectious disease, but there are medications, and we need to make sure that we support the patient. We provide all the support needed, and besides that, we need to screen everybody in their families and their close contacts, and make sure that no one um, has been infected and can can die from TB. So reassuring TB patients and making sure that they understand that this is after, if they take the treatment very well, they'll be fine. Is one step, and above all, I have to be the compassion. You have to support the patient in that journey, because most of the time, as I said, those patients are very poor. They don't even have money for transport. So when we talk about the social support, it's very critical for TB patients. Most of them they're very poor. They need social support. They need counseling. They need to be heard. They need their families to be safe. So we have to feel their pain and be with them in that journey.
Mhm. Yeah, something that we hear a lot when we talk to survivors is that they get so anxious and so guilty about all of the people that they could have affected, and We work very closely. I'm sure you know We Are TB, the TB survivor support group that we're all very good friends with. They've talked a lot to us about, feeling like it was their fault, right?
Yeah,
And feeling a level of guilt. And we all know that that's not true, but it's hard to know that in the moment. So
yeah.
that really stood out. Um, and so we have a couple of other questions in here. One, I'm not 100% sure we can follow up with this person with more information, but are you able to talk at all about how the MOUs between the US and the other countries are impacting TB care specifically? We've been talking about this and advocating on these for a while, and so we're all very concerned about those impacts.
Um, well, I'm aware that the US government is establishing MOUs with different governments. And one of the areas that these MOUs are targeting is HIV services, and human resources for health and TB. But to be honest, I don't have the details about the MOUs. I had different stories, but I cannot comment
Yeah. It
much.
might take us a little while to understand actually what those impacts end up being too. But we'll keep bothering Vincent.
Exactly.
Yeah. Okay, so we have another question where people would like to hear a little bit more about the TB Hunter dashboard. A lot of us are very data nerdy people, and so we'd love to hear a bit about, how that was developed, what you were looking for in it, how it's worked out. Just tell
Yeah.
us all about it. Give us the cool numbers.
Thank you. Thank you. So, yeah, we developed the TB Hunter system 3 years ago, um, to respond to some issues that we were having in the clinics. Um, when I started to think about the how I can frame the system, I did a visit to one of our clinics in rural Lesotho, and I was looking at, the number of patients who came that day, and how many people have been screened, and how many have been found presumptive, and out of those presumptive, how many have been tested, how many went back home without being tested, and where do they live? And I couldn't really uh, get answers with the current with the then data systems that we had. We were using paper-based registers, and each clinic had 6 registers. There is a register for TB screening. There was a register for presumptive TB. There is a register for lab. There is a register for contact tracing. There is a register for treatment initiation. And these registers are like, they cover the whole table. And when you are trying to locate one patient from the entry point at the clinic to the exit to see, like, has this patient been diagnosed, or has this patient been screened, or we couldn't really find the answer. Then I started thinking about the TB care cascade. How can we have a system that can help us to generate live data on the TB care cascade, from screening to testing to contact tracing to treatment initiation to post-bilang disease in one platform? And how can we develop a system that can show us which villages has high number of TB patients, that we can consider, okay, this is a TB hotspot. We need to go there and screen everybody. We spend a lot of money on clinical outreaches, but randomly we can decide to go to this village or this today and this other one the next day. But when you have a system that is showing you, okay, this village has high number of TB patients, you put that village as a priority. So then we started to work with our medical informatics team to develop this system. We developed this into ComCare, and it took us several months to really develop it and make it and pilot it. And right now, it has even advanced features, including sending SMS notifications to patients, to contacts, to clinicians, and it is guiding clinicians on how to screen. For example, if you have been screened and you are positive on certain symptoms or signs of TB, the system will flag that and say like this patient needs to be tested. Or if the AI score is above this threshold, the system will just tell you, okay, this patient needs to be tested. So it is like an interactive system,
Mhm.
and at the end of the day, it can generate a map showing where are those patients from.
That sounds like an absolute just a game changer in terms of access. And can you tell us a little bit about where this system is? It only in Lesotho? Is it expanded? Um, is it something that can be scaled?
Yeah, it is something that can be scaled. It is right now it is being used in Lesotho, and even I'm here in the US, but I'm able to see live data from the
Mhm.
district where we are implementing the TB elimination project. It is really a cool system. I have the dashboard. The data is
Mhm.
is flowing, and we can see where are the gaps. If, for example, we are not able to test everybody, and then we can know, okay, maybe there is a problem of supply chain of testing commodities. Maybe there is an issue of human resources, like lab technicians. So it helps to take action on time.
Mhm. That's great. One technical question that has come in through the chat. Can you talk about what it means to be presumptive versus one of the other statuses that you talked about?
Yeah, yeah. Good question. Good question. So, um, when when you do the TB screening, right? There is a list of symptoms that we go through, like someone is coughing for more than 2 weeks, someone has lost weight, someone is having night sweat, someone is having a poor appetite, and other risk factors. So if someone it says yes in one of those symptoms, you are presumptive. Uh, 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 but if all the questions on the symptom screening is no, it means
Mhm.
you are not
So
you are
it,
okay.
yeah,
Yeah,
we can assume this person probably has
yeah,
TB, and
yeah,
they're
exactly,
definitely we're just waiting for it to
exactly,
confirm.
exactly.
But
Now we are also using X-ray uh,
Mhm.
chest X-ray as a screening tool and artificial intelligence. And the artificial intelligence is giving a score, a probability. Um, and right now we are saying if the score is 0.5 or 50%,
Mhm.
uh, that patient is presumptive. It's another way of saying, okay, this is likely TB. Um,
Mhm.
but if you have lower score, the likelihood that you have TB is low.
Right.
So that is also we classify those as presumptive.
Which makes sense, right? I mean, there's only so many radiologists to read all of them, but also,
Yeah.
it helps kind of just understanding, the landscape and where everything is there. Um, can we have time, I think, for like one or two more questions? But I think I was wondering if you could talk a little bit about HIV and TB co-infection and how that is kind of playing into care, especially in rural communities.
Yeah. Um, HIV and TB, these are very, if I may say, very good friends.
We wish they weren't.
Yeah, yeah. So, in Lesotho, the HIV prevalence is one of the highest in the world. I think it is about 22, one in four people, for adults is living with HIV. And when you look at the TB patients, half of them are infected with HIV. So, uh, yeah, TB and HIV, unfortunately, these are diseases which are like base comorbid conditions. And you will see like uh, for someone who is infected with HIV, it is a bit difficult to diagnose TB because even chest X-rays can look a bit different from a non-infected patient. So that's why when we are doing this screening, we are we are combining clinical screening and X-ray screening, and we use this artificial intelligence, but also we also have the radiology component. And unfortunately, the treatment outcome for TB and HIV patient, those who are co-infected,
Mhm.
is poor compared to TB alone. Uh,
Right.
and this is because, someone would be dealing with HIV, but at the same time with TB. And even the management will become a bit difficult because someone you have to treat both.
Mhm.
And you can imagine like taking TB drugs and HIV drugs at the same time for someone who is very poor.
Each of them are just so many.
Yeah, exactly, exactly. Yeah,
Yeah. That sounds like the worst possible combination. And we know that if you have a compromised immune system, you're more likely to have active TB. And so, yeah,
yeah, yeah,
it's one of those we have to fix all of it, right? You can't just
exactly,
just fix
exactly.
one
Mm,
piece.
mm.
All right. So I'm going to ask you our last question, and we ask the same last question in every TV Ed Talk because at TV Faders, we are very big on the concept of hope, right? That's something that's very important for us. It's the only way that we can kind of keep
Yeah.
going. We hang on to the idea that we will end TB in our lifetimes. So what's something that's giving you hope in the world of TB right now?
Yeah. Yeah, the first hope is you, is us, the advocate. We understand that TB is a curable disease and preventable disease. And your voices are the hope. We need to keep raising our voices to make sure that the world understands that this is a disease that we can together as a global community fight and win.
Mhm.
And the other hope is I've seen like there are new technologies, really good, cool technologies like artificial intelligence, point of care molecular test. Recently, I saw like WHO has approved tongue swabs.
Mhm.
As a
Yeah.
clinician, we've been struggling for patients, for example, kids.
Yes.
If you are looking for a sputum from a kid, it's not easy. It's not easy to get a sputum sample. But right now there are like tongue swabs. There are you can test TB in urine.
Yeah.
Um, and so those are cool technologies that are developed but still they are expensive. We need to push to lower the cost to make sure that low income countries can have access to those testing tools. We need to make sure that medications are available. And even for drug-resistant TB, now we used to give injections for drug-resistant TB. Now there are oral drugs. We need to keep advocating for investment in research for new drugs, new vaccines, new testing tools. So that is my hope. And I think together we can raise our voices, we can advocate for these technologies and more investment in, in testing technologies, new drugs, new vaccines to make sure that the world can be safe. That is my hope.
Yeah. And I'm choosing to be optimistic about it, right? We've seen what happens when we put the pressure on and we get some of the money back and we get some of the prices lowered. And, access to the scientific advancement is a human right. And we
Yeah,
will, yeah, we will just keep shouting about it until they listen.
exactly.
But yes, there's a lot of things to be hopeful on. So I will give you your night back, but I have a couple of quick announcements for our TB fighters before we go. The first one, as always, wanted to link everybody to our friends at We Are TB. They're a confidential support group for TB survivors. The link should be in the description of the video, the doobly-doo. So if anybody would be interested in being in touch with them, it's some of the best people we know and would encourage people to reach out or recommend them. Also, our TB book club is starting Illness as Metaphor, and they're reading that through the 31st of May. So there's still time. You can also join that from the links. It's a very fun group book club. It doesn't matter if you join late or don't read the book until the last week of the reading period and then read it really fast, which I usually do. It's a great conversation. And then the last reminder I'm going to give everybody is to make sure that you're subscribed to the TB Fighters newsletter. We have some potential things coming up that are very exciting, possibly in partnership with our friends at MSF about access to the medication lenacapavir, which is an HIV preventative medication. But as we just talked about, we know that that is very closely related to TB. So keep an eye out for some potential updates about what we're working on with them. Those will come via our newsletter. That is everything from us tonight. So, as they say in our hometown, don't forget to be awesome.